The statements and opinions expressed in this episode are those of Dr. Sigman and his guests, and do not necessarily reflect the views of Veradigm.
It's time to do healthcare smarter. This is Smart Medicine, hosted by Dr. Scott Sigman and powered by Veradigm. What was once an overlooked field of medicine is now front page news. You can't open a headline without hearing about the latest in weight loss medication. But look, with all this buzz comes a lot of questions. So call me Sherlock Holmes, because today I'm launching an investigation into GLP-1s. I want to understand what they are, how they work, and most importantly, how they are going to affect patients. And while I don't have a Dr. Watson, I do have Dr. Robert Kushner, and calling him a pioneer in obesity medicine would be an understatement. In this episode, we'll unpack how obesity became the disease that got away, and how GLP-1s are transforming the way we think about weight and wellness. Let's go back to 1979. A researcher named Richard Goodman was studying the anglerfish. Yes, that strange deep-sea fish with the light on its head, and found it was a great source of material to study how the pancreas works. From that research, scientists discovered a gene that makes several hormones, including one called GLP-1. A few years later, they realized this hormone could help the body release insulin and lower blood sugar, a major discovery for diabetes care. Fast forward to the 1990s. Another scientist, Dr. John Eng, made a surprising find, a substance in the Gila monster's venom that acted just like GLP-1, only it stayed in the body longer. That became the first GLP-1 medicine approved by the FDA in 2005. So yes, this drug's research started with an anglerfish and a Gila monster. Sometimes science really does come from the most unexpected places. Today, I'm thrilled to have Dr. Robert Kushner, a global leader in obesity medicine, professor at Northwestern, and one of the pioneers redefining how we think about weight metabolism and wellness. Dr. Kushner, you've dedicated your career to helping clinicians and patients view obesity not as a moral failing, but as a chronic, treatable disease. As an orthopedic surgeon, I help manage patients with obesity every day. I just want to say I'm truly excited to learn more, and welcome to the Smart Medicine Podcast.
Well, thank you, Scott. That was a wonderful introduction. I'm very happy to be here.
Well, fantastic. All right. We usually try to start in the beginning, so let's start with sort of your origin story. And how did you first become passionate about obesity, nutrition, especially at a time when, few physicians were truly recognizing the significance of obesity in our healthcare?
My origin story began with reading a short message in the American Medical Association newsletter. They had a paragraph on trying to get medical students interested in nutrition. So I was a senior last year in medical school, and I did 6 weeks at UC Davis learning about nutrition. It changed the entire trajectory of my career. I fell in love with nutrition. It connected all the dots: metabolism, endocrinology, sociology, behavioral health, and so forth. So after finishing internal medicine residency, I did a fellowship in nutrition and a master's in nutrition, and I was off to the races 40 years now, chasing areas interested in nutrition, and out of that came an interest in obesity. I started with undernutrition, TPN, hyperalimentation, enteral feedings, shifted to obesity, which I've been doing now for well over 4 decades. Who knew? Who knew at that time it would take off?
Yeah, 40 years ago, you were totally ahead of the time. As an orthopedic surgeon, one of the things that we really feel is super important now, which has been really missing from our paradigm of treatment, and that's perioperative nutrition and the essential amino acids, and being concerned about sarcopenia for our patients and getting them to a healing response. So your message is really permeating through general medicine all the way through even to orthopedic surgery. So you've said that obesity is one of the most misunderstood diseases in medicine. And so what do most physicians just not get? What are we missing?
We talk about endocrinology and heart disease and pulmonary medicine, kidney disease. It's the one that got away. We didn't focus on it. I think what we are learning now, and it's an exploding field, as you well know, like you said, as an orthopedic surgeon, is I think we are recognizing that it is the foundation for so many chronic, progressive, non-communicable diseases. In fact, it even affected us with a communicable disease called COVID-19, when individuals living with obesity were more likely to be hospitalized, get in a ventilator, and unfortunately succumb to the infection. But as we learn more about the health consequences of excess body fat, and we call it dysfunctional fat, that's that visceral fat in the abdominal cavity, it causes inflammation throughout the body, we are realizing that it's the harbinger for so many of the chronic diseases, cardiovascular disease, diabetes, cancer, heart failure, and yet sleep apnea and arthritis of the knees. Now we're getting into your area. So it touches upon everything. And all this time, we don't have much education about obesity in medical school. We're still trying to catch up. In our postgraduate education, still very little education about obesity. Yet when you enter practice, 3 out of 4 individuals are overweight or have obesity. So we're missing it, but we're trying to catch up.
If not the physicians themselves too. I mean, it's really fascinating. And so you're almost, I'm going to call you the godfather of modern obesity medicine, okay? Because you actually founded, or was one of the founders, the American Board of Obesity Medicine, right? So you really tried to change the paradigm as to how we were thinking about nutrition, and then of course obesity as well. So tell us about what the goal was and how has that really changed how people are thinking about obesity medicine at this time?
Well, let me bring you back to 2011 when this all went down. The prevalence of obesity in the United States was 35% among adults. You know what it is now? Over 40%. So we didn't make much headway there. But we knew even then patients were looking for clinicians that would help them manage their weight. We knew that trainees we needed to do a better job educating trainees, and they didn't have a goal. So by setting up a board certification, the medical students that I teach every day could see, okay, I could see where I'm going. I'm interested in this area. I could actually take this on as a profession. We also had a society called the Obesity Society where members wanted a home, and we wanted a designation for the unique education and knowledge we have. So all forces led to developing a certification examination so that you could highlight your interest in obesity and be designated by that. Over that time, it has grown tremendously. Remember Field of Dreams, right? If you build it, he will come. But it's actually what I mean, they will come. Over the past 12 years, we have now grown to 10,000 diplomats, all physicians. It is the most rapidly growing, expanding specialization in medicine above all the others. So every year we have over 1,000 diplomats taking the examination. So clearly there was a need there, and we thought about it in 2011, and it's heartening and rewarding to see that it indeed has come true.
Yeah, and you've got some new tools in the bag now. We're going to get to that. But I'm a surgeon, so I would be sitting in the operating room and I'd watch my buddies who are general surgeons who really sort of track towards the obesity surgery. So in orthopedics, for example, we went from open operations to arthroscopy. Now we're using robots to do a lot of the stuff that we do, which have really transformed the way in which we treat medicine. And obesity management from a surgical perspective went through a similar evolution. It was an open gastric bypass. Then there's the minimally invasive, the sleeves, the laparoscopic bypasses. So from your vantage point, how has this surgical evolution shaped the way we think about obesity as more of a treatable disease? And then with the caveat as well that with the GLP-1s coming out, don't spend too much time on it because we're gonna do that a little bit. But is that going to change the surgical field of obesity?
Yeah, it has already, Scott. I'm going to go back to 2011 just for a moment, just as a thread of starting the American Board of Obesity Medicine. At that time, the cornerstone of treatment, as it still is, but almost the only treatment we had back then was lifestyle counseling, diet, physical activity, behavior. We didn't really quite quite know at that point it was a disease and this long-term progressive problem. And then we had a few medications. Believe it, at that time, the only drugs we had were phentermine, which is an amphetamine-like derivative, and orlistat, which blocks dietary fat. That's all we had in 2011. And then we had bariatric surgery. So if someone didn't respond to lifestyle, the only thing you really had to offer is, what do you think about bariatric surgery? And at that time, we were doing laparoscopic procedures, so the operative time and experience was completely different than the open procedures. But there's this huge treatment gap between lifestyle and surgery. So surgery was doing very well, and I'm a strong advocate. It is still now the most durable approach that we have for severe obesity. But then comes filling a gap with the GLP-1 medications, which we'll talk about a little bit more now. Our surgical colleagues are starting to feel it in the numbers of cases that they are doing. And if you are a patient with severe obesity and you have the option, can I try a highly effective medication that I take once a week as an injection and potentially lose 25 to 30% of my body weight? Or do I go to a surgical procedure and lose about the same amount of body weight? Most people go, let me try medication first. Now, there's pros and cons between the two. I can see a lot of people going to bariatric surgery right away, but most people say, you know what, let me hold off on that surgical procedure. Let me try a medication first. So it's affecting the surgeons.
Yeah, it's interesting. It's not too dissimilar for cardiothoracic surgeons and for bypass surgery with these medicated stents that we have now. And perhaps even, we'll talk about this some more, with our GLP-1s, we might actually really start reducing cardiac disease as well. So let's give a little shout out. We love to give our shout outs to our guests. And you've written 15 books, 56 chapters. I mean, I can go on and on. Your CV goes on forever. But your newest book, Patient-Centric Weight Management, what's the heartbeat of the project? How is it capturing sort of the evolution of obesity care?
Yeah, thank you. So it's Patient-Centered Weight Management, the 6-factor professional program, a toolkit. So I have taken my own clinical research and put it into the book. It uses a targeted therapeutic approach to providing care. It starts off with a self-administered questionnaire that patients take. It gives the clinician a head start on where do I need to spend time with this patient based on what their challenges are.
So I like how you've got the previous one was more for the patient. Now you've got one for the doctor. All right, so let's get to it, right? Let's face it. What's the big thing right now around obesity in the U.S. and around the world? And that's GLP-1s. So the year was 2006. Eli Lilly releases their first GLP-1, which was tirzepatide. Truly, it was really for diabetic management. This was not about weight loss at the time. That wasn't really on their horizon. So my mother, Judy's listening. We have a thing, Bob. You need to be able to describe these things so that everyone can understand it. So what is a GLP-1 and how does it work?
So GLP-1 is a naturally occurring hormone that we all produce in our gut. So when you start eating a meal, right, it takes a while, you start feeling full, your appetite goes down, you slow down your eating, and eventually you feel full. So how does that happen? It happens in large part because hormones are being released from your gut. These are called gut hormones. They go up to your brain and tell you, I'm feeling more full, I am less hungry. GLP-1 is one of the naturally occurring hormones. So what the pharmaceutical industry has done is to take the GLP-1, harness its effect by synthesizing it, turning into a drug, and giving it back to people at supercharged doses. The best example I give you so people understand, it's like taking insulin, which is a naturally occurring hormone. But if you have diabetes, some people get hormone given back to them at very high levels and controls their diabetes. So it's harnessing or mimicking a naturally occurring hormone that we're giving back. At this point through an injection, later it'll be orally. So that's what it is.
Awesome. Fantastic explanation. My mother, Judy, will call me later on today and she'll tell me you did a nice job. Okay. So the management of obesity has evolved tremendously. You've talked about this when you first got started. It was about diet. It was exercise, behavioral, psychosocial type strategies to try and help people to not be so dependent on food. Then the surgery came in and then you sort of had that dichotomy. It was either all in or all out as far as the surgery was concerned. But obviously we now have these new very powerful medications that are coming down the pipeline. So from your perspective, how has this evolution reshaped the way we're thinking about obesity care today for the average patient that's walking into your office?
I'm going to give you another example to answer your question. And the example is the wonder of we call biologics. Biologics is a commercial that everyone sees every day. How is it that you could use the same type of treatment that will take care of things like Crohn's disease, ulcerative colitis, psoriasis, eczema, rheumatoid arthritis, and you keep going? They're called biologics. They target different aspects of the immunological system. It was a breakthrough for all these autoimmune diseases. That's how we think about GLP-1 and all the other drugs in that thing. Prior to understanding the role of gut hormones on appetite, we were using drugs that work directly in the brain with different side effects and dry mouth and headache and hypertension and elevated blood pressure. We found for the first time, and I've been in the field for 4 decades, this has been transformative. What we found is the secret sauce. It's in our gut. By harnessing these gut hormones in combination or single agents and giving them back to people, we have found how to treat obesity. Obesity, we think of it as a chronic disease for most people. Multiple determinants, right? Where you live and physical activity and genetics and all this. But biologically, we now feel that people who are predisposed to developing obesity have an appetite dysregulation. They just don't feel, even though they produce these gut hormones, the brain is not getting the signal to stop eating or feel full. So they take in a little more food than they need. So they put on more weight, and the excess fat causes inflammation. So that's the disease of obesity. We now have the target that we've been looking for a long time to make a big difference in the lives of people who are living with obesity. And what do they say when you give these drugs? They will tell you, you know what? The food noise is gone. I'm not thinking about food all day long. I actually can eat amount of food that's appropriate for me and not be hungry. I could walk past all these desserts and they're not calling out my name. I'm not wandering into the kitchen again. I am content. And this is what I've been looking for my whole life. That's what many of these people express. Now, it's not a wonder drug. It's not a miracle. You always have to take care of yourself, and physical activity and diet is still cornerstone. But it has made a breakthrough in treatment of obesity for people who are living in this area.
Let's talk a little bit about that, because we've sort of been talking about inflammation and other things. It's not just about weight management. There are some really exciting things coming out. There was a study from the VA, for example, where it looks like maybe we can get heart disease better, and maybe the kidneys are going to work better. Maybe we might not have Alzheimer's. So it really seems like there's going to be this expanse of potential treatments outside of just obesity. And I like to say that the human species is made to move. If you stop moving, you die. I mean, it's just the nature of who we are. And so I almost get a sense that these GLP-1s are going to be like the penicillin of our era, this amazing drug that was just identified and found and has been used for so many different things. So where do you see this going outside of obesity management as well?
I'd say we are at the end of the beginning. That gives you an idea of how expansive this is. GLP-1, Scott, is only one of a whole range of gut hormones that we're starting to understand. Other ones to memorize these, but are GIP, glucagon, amylin. So drug companies are combining them almost like a mad scientist in a chemistry lab and seeing what the effects are. We have already established benefits in reducing a second heart attack or stroke in someone who had it previously who is living with obesity. We already know they're beneficial for diabetes. As you mentioned, it started off in that. They are reducing sleep apnea, so people are getting off of their CPAP machines. It's improving knee arthritis, so you're going to see it in your own office, right? Improving chronic kidney disease, heart failure, with we call preserved ejection fraction, and other areas that we're also excited about, although it's not my direct area of research, is use in substance misuse, whether it's opiates or cigarettes or alcohol, as well as Alzheimer's disease. The first one, the substance misuse, has to do with its effect on the reward centers in the brain. As a clinician, when we started using these medications, I didn't think about this, but people would come in and go, you know what? I'm not drinking as much as I did, or I'm not smoking as much, or I'm not shopping as much or gambling as much. It gave us an understanding that these receptors for GLP-1 are in the reward centers of the brain. And now we're also being looked at for Alzheimer's disease, which has to do with inflammation and plaques. So panacea, I don't know, but they are no longer considered weight loss drugs. In fact, they're no longer considered diabetes drugs. They're drugs for multimorbidity, multiple chronic medical problems or behaviors. And I think we're at the end of the beginning, is what I said.
Yeah, fascinating. We're going to talk a little bit about the reimbursement and cost side of things, not just for the individual patient, but for perhaps population medicine as well. But it seems like there have been reports, though, that some people are not staying on the meds beyond 2 years. And so as many as 85% of patients will discontinue. I live in a digital world now, and we have many guests that have been on the show talking about the wearables and all of the ways in which we can affect behavior by monitoring things. So do you feel like perhaps these digital tools and the coaching and things like that might actually sort of change the way people are perceiving these medications and how they should be used?
Well, I think they will, but I want to go back to the people dropping off of the drug. I want to make sure that we normalize these medications to other medications. If you take other categories, people drop off. People often don't want to take medication for a variety of reasons. And there are real world data coming out that you've referenced that 50% are off in about a year and a little bit more, 70% and so forth. We don't really know why. As a clinician, I could tell you the number one reason people go off the medications currently is they can't afford it. The insurance doesn't cover it. They change jobs and they've lost coverage, or they just can't get access to it because of shortage, although that's over now. Other reasons, of course, are GI side effects, the belief in obesity, which is somewhat unique, that it's my problem. I should have personal responsibility for taking this on. I'm going to use medication to get my weight under better control, then I'm going to take it from there. And that's a misnomer because it's not a fault. It's not a problem of willpower. But to get to your question, your targeted question about what other resources would help people keep it on the medications, absolutely. We learned a lot during the behavioral treatment studies, like self-monitoring help, stimulus control, coaching, accountability, social connection, and social relationships and other support. All of this helps. So it's a mistake for people to think, if I just take this medication, I'm good to go. I think you're going to find out that you're not going to do as well as you can. You're not going to improve your health as much as you'd like. And you may end up actually regaining the weight when you go off the medication. So it's a bundle. It's not an either or answer.
Yeah, I like that a lot. The entire process still needs to be worked together. Let's have a little fun. Whenever there's new medications and there's the social media that's out there, we're going to do a little myth versus reality thing here as far as GLP-1s and obesity. So let's start with the first one. Obesity is really just about willpower, right? If the patients just worked at it a little bit harder, they wouldn't need medications or surgery.
Yeah, let's throw in sloth and gluttony and moral problems as well in that question, right? What's wrong with you? What? It couldn't be more misinformation, and that leads to the stigma and bias and discrimination against people living with obesity. Even to today, and I don't think that's changing at all. It couldn't be more of a myth than anything. We think of now as a chronic disease, just like diabetes. Can you imagine someone with diabetes say, if you worked a little harder, you can get that blood sugar down. You just need to work harder to do that. It's a myth. And we tell people it is not your fault. It's not about willpower. It's not about laziness. You have an underlying medical problem, predisposed to putting body weight up. We have a whole range of treatments available, but it is not your fault.
Awesome. We appreciate that. Okay, number 2, GLP-1s are a quick fix. Once you stop, all the weight comes back every time.
Myth and truth. The myth is that it's just a quick fix. It's not a quick fix. It's like, again, I'm going to use comparator diabetes. We got you on medication, your hemoglobin A1C and glucose under control. You could stop the medication. What clinician would say, stop the medication, your sugar's now under good control, right? You'd say, we finally got there, now I'd like you to stay on the medication. Maybe we could tweak it, change the medication, maybe, but we're going to continue to follow you. So it's not a quick fix. However, the second part of that is that the weight will come back is very, very true. These medications treat an underlying biological problem of the appetite dysregulation. If you stop the medication, and I tell patients this, they say, what happens if I go off it? Or will you work with me to go off it? I'll say, I'll work with you to go off it. Shared decision making. But this is likely what you're going to find. Your thinking of food is going to come back. You're going to start getting a little hungrier. You're not going to be as full. Food is going to be more enticing. It's going to be very, very difficult. So we really think of it as a long-term treatment when you're on these medications.
Yeah, and especially when it comes out to pill form, it will be even easier to have that conversation as well. So really excellent. So, all right, here's another one. Just like the mRNA vaccines, right? This is a new drug. We don't really know about its safety profile, and we don't know about the long-term risks. So therefore, I don't want to take it.
So the GLP-1s, believe it or not, first came out in 2005 for treatment of diabetes. So we're talking about 20 years of experience with the GLP-1 kind of medications, although they weren't approved for obesity until 2014, and then the other two were in the past several years. But if you multiply that 20-year exposure to around the world, because these are global medications, you're probably talking about millions of patients' exposure to these medications. We have a pretty good understanding of what the side effects are, what we need to look for, how to counsel patients. We have not seen anything around the corner that we have been surprised about or we are worried about after 20 years. We feel they are safe, but we use them with caution in some people, and we have that conversation with patients.
Dr. Kushner is setting the record straight. GLP-1s go straight to the biological root of appetite dysregulation, but there's another root problem as well. We need to talk about affordability. These medications have incredible potential for change. But the question is, how do we make sure the people who need them most can actually get them? Before we look ahead to the future of GLP-1s, this episode of Smart Medicine is powered by Veradigm. Veradigm connects payers, providers, and life sciences through data-driven insights that make healthcare smarter. Let's start talking about now the future of care with GLP-1s. And so the healthcare and the insurers in particular have not been very happy about the cost of this medication, right? Which is truly a conflict, right? Because if we think perhaps it may be saving healthcare dollars down the road. So we know that it could be as much as $1,000 a month at this point. There's some good news. Actually, Costco just struck a deal just the other day with Novo Nordisk, and Ozempic and Wegovy are going to go down to closer to $500 if you're a Costco member.
Scott, that's a deal. That's a deal. $500 a month. That's a great deal.
Right? I mean, everybody's running down to Costco. You're going to get all your big bags of food and you're going to get your GLP-1s. You won't have to eat all of it. So there may be a conflict for Costco there too. We'll see. But we'll see how it rolls out. But I mean, what are your thoughts? Because I firmly believe, yes, this drug may be expensive where we are right now. The CEO of Eli Lilly was just on the All In podcast really talking about how he wants to try and help reduce costs. Because I do think for population-based medicine, if we can reduce cardiac issues and diabetic issues and renal issues and knee arthritis and all these things, can we save some money to the overall system?
Oh, yeah, absolutely. If we play the long game, to me, there's no question the benefit of these medications. The problem is currently it's increasing this inequality gap. It's the haves and the have-nots. And you brought up Costco, and I saw that in the paper today. Hey, such a deal, $500 a month out of pocket. Who has that? The haves, right? The people who have the ability. Clearly, the prices have to come down, whether it's through competition, availability of generic medications. In fact, semaglutide is going generic in Canada and India, to name two countries in 2026. That's going to bring that down. The birth of compounded medications, right, was driven because of that. Who knows what you're getting in compounded medications? You could have legislative changes, right? We know that, at least under previous administration, so many drugs every year, right, were being negotiated down as for Medicare and so forth in order to bring the cost down for Medicare, at least. I will tell you, you may or may not know, Scott, that the WHO essential medicines list included GLP-1s just a month ago. So what that means is that countries should start considering these medications as an essential medication. Doesn't mean the price is coming down, but a good example is HIV drugs. When they were made essential drugs by the WHO, it was globally available. Negotiations occurred. That was when George Bush was the president, and PEPFAR and so forth, and made HIV drugs available around the world. So there is a direction we're going, but I don't see it around the corner as long as these prices are as high as they are.
Yeah, I mean, if I'm the CEO of Blue Cross Blue Shield and all these health benefits downstream are going to be happening for my patients, I'd be like negotiating up a storm with these pharma companies to say, hey, we'll buy it. We're going to put it on everybody. We're going to mandate this for every single patient. And mandates don't work in medicine. But the idea being, for the right person, we can use a lot more of this medication and hopefully we'll reduce costs to the system. And so speaking of which, I mean, I think Eli Lilly sounds like they have an oral prep that's coming out relatively soon. I mean, I think that's going to help with accessibility and adherence, right? Don't you think? And then along the same line, is this going to be like statins and aspirin? Like, we're going to tell everybody you should be on this.
When semaglutide came out in 2021, I was actually a corresponding author on New England Journal. It's like a big deal for me with the interviews and all that. The New York Times called it a game changer. And it is for a lot of the reasons you and I have already talked about. I, however, think the real game changer is going to be the oral medications. They are not peptides, right? They're small molecules that you can make in a lab. So what that does is it makes it cheaper to manufacture and distribute. It does not need refrigeration in the supply chain and truly could be globally available and shipped as such. Whether the pharmaceutical company will price them low enough, I don't know. But there are two oral medications likely approved probably 2026 or so, which will be, one is called orforglipron, that's the one he talked about from Eli Lilly, and the other is an oral semaglutide by Novo Nordisk. We have an oral semaglutide now called Rybelsus. It's for diabetes. It's a higher dose than that for obesity. So that's going to be a big change, and I think it's going to make it available to so many more people around the world than a once-a-week injection. And also for the climate, right? You got the needle, you got the syringe, all these things. Where are they going? Oral medication, it goes all in you, right? So there's no climate or environmental problem for that.
Yeah, it certainly seems like accessibility would be improved dramatically. So now you brought this up too, with as far as other countries around the world now integrating GLPs into a broader public health strategy. Are you pushing for that? You're heading down to DC and talking to our Congress people and trying to influence that perhaps from a global population-based medicine perspective, we should be using these medications more?
Yeah, that's done mostly through the WHO. There are advocacy groups that are really promoting this concept. And so the WHO looks at obesity as a chronic, non-communicable disease that probably is overarching a lot of the other chronic diseases that are already covered by the WHO. It's really a long journey. I want to reinforce something I said earlier, Scott, and that's discrimination and stigma. Probably more so in Western countries regarding that. And in other countries, those who have excess body fat are actually more the rich and those that can afford the food, where the rest of the population is not so. Here, there's just a lot of stigma and bias. So we have to cut through that. I think we actually, to make forward progress on obesity as far as getting the message out more.
I love it. So one of the other things that's really become a big concern, and that's particularly, for example, postmenopausal women. And in particular, there has been some talk about some low dose or microdosing of GLP, that may actually help with some of the hormonal imbalances, the complex metabolic issues, as far as weight gain as well. Do you see that that's something that might be coming down the pipeline?
I think those will be natural directions that people will take. This microdosing that you mentioned really came out of the compounding companies because the trade products don't have microdosing. Microdosing, by definition, is a very small dose from what a normal starting dose would be. And a recent study was actually published in Diabetes Care, looking at patients with diabetes who microdose versus using what the trade recommendation is on the package insert. It turned out that people tolerated the drug better by microdosing rather than jumping to a higher dose. They stayed on the drug for a longer period of time, and at the end, there was no difference in weight loss or diabetes. So I think we're going to see microdosing, just to bring up that. And what you're also talking about is other things, whether it's a weight gain through perimenopausal transition, maybe microdosing for substance use maintenance. So I think the horizon is wide open now where these drugs are going to go. And you mentioned statins before. This has the opportunity, where statins is just reducing cardiovascular disease. This has the opportunity for a whole range of chronic diseases that are all based on this dysfunctional fat and excess body fat.
Yeah, no, absolutely fascinating. So as we're sort of coming to a close, and I'd like you to sort of say, you're sitting in a room, you're speaking directly to a patient. This patient's feeling discouraged after years of struggling to lose weight. What message of hope are you giving to these patients at this point about where obesity care is headed today and the future of our medicine?
First, I'd start off by saying it's not your fault. I mentioned that earlier, and it is so important because of pervasive stigma. I would talk about obesity as a chronic progressive disease for most people or condition. I would ask them to seek help to assist in their journey, focusing on a healthy lifestyle behaviors as a cornerstone of treatment. But if that was not effective enough to control your weight and gain health, there's a spectrum of medications available or bariatric surgery that can help them. Talk to the healthcare professional for guidance, get resources and referrals if needed. You're not alone.
That's wonderful. Listen, Dr. Kushner, this has really been amazing. We want to thank you for your incredible contributions to the field of obesity, the evolution of obesity care. Your decades of research, education, patient advocacy have really transformed the way we understand and treat this complex disease. It's been an honor having you on the Smart Medicine podcast, and we are grateful for the hope and progress your work continues to give to humanity and our patients.
Thank you, Scott. You're a gracious host, and I really enjoyed being on the show.
What a powerful conversation with Dr. Kushner. Obesity isn't a moral failing. It's a chronic biological disease that deserves real medical care and compassion. And it's exciting to think that we're entering a new era of treatment, where GLP-1s are giving patients tools that truly work. Access, affordability, and education are the next frontier. At the end of the day, this is a story about hope. Proof that when science meets patient care, we can do healthcare better. And to me, that's smart medicine. I'm Dr. Scott Sigman, and I'm glad you're here. Catch you in the next episode.